Yes, we're going to be talking about sort of consent and the issues that we come across as clinicians. And certainly, we have student midwives that have expressed concerns over some of the things that they're seeing in practice. Much of my background and my research background, if it isn't looking at home birth, it's looking at some of those uh, consent issues and issues around what we tend to term as birth outside of guidance. And I'm going to be challenging you today to start thinking about this slightly differently because I've only got 15 minutes and I could talk about this for hours. So this is going to be a quick win. And I say a quick win, but I'm not sure it is because I am going to be asking people to think sort of systematically as part of the systems you work in, but also sitting with your discomfort around some of the issues that come up with this and how just by changing our language can reframe how we think about the care that we're providing and the care that we're planning. So I framed it around the problematic terminology of birth outside of guidance because that's where most people are understanding this sort of care that we're providing and care planning. Why am I looking at this now? Well, I've been looking at it for a very long time, and there is more and more scrutiny over women and other birthing people that are making choices that perhaps are making us uncomfortable, that make services uncomfortable, that we might see as extreme or not. They might be small choices, and I'll touch on what some of those have been when I've looked at them in my research. But equally, there's been a number of focuses made on by our regulator, by the NMC, and also by the RCM to try and provide support for midwives and other clinicians that are care planning for women who are making challenging decisions. So what you'll see on the screen there, you'll be probably familiar with the RCM Care Outside of Guidance. And most recently, if you saw it last week and over the last kind of 2 weeks, the NMC have published their principles for supporting women's choices in maternity care, addressing some of those issues around things like what they've termed unregulated birth workers, but also addressing and consolidating what our rules are, what we can do to support women. But what I found really interesting is the language and terminology still used in this space. And the wonderful Tracy McCormack, if you watch the videos that the NMC have provided, says at one point towards the end, I don't know why we call it this, it's just personalised care planning. And that's part of what I want you to think about when you go back into practice, amongst some other things as well. You will also notice as well that we're focusing quite a lot now on the outcomes for women making challenging decisions, and the data that certainly the NMC have provided, and you'll see their MNSI, is predominantly around those poorer outcomes. But we're looking at those big choices. We tend to focus on those choices, such as your VBAC2 at home that's decided to have twins, for example. But it's more nuanced than that. And all of the issues around consent and how we obtain consent and how we frame what their care looks like can be applied whether or not it's someone making a seriously challenging decision or whether they've just said, no, thank you, I don't want a vaginal examination, which ties really nicely with what Sue was talking about. So we just want to touch on and acknowledge some of the anxieties around this issue. Because when I speak to midwives around the country, when I speak to systems around the country who find this particularly challenging, what they tend to say is, but I don't feel protected. I don't feel that I can support women to make choices that looks outside of guidelines, whether it's declining care, because I'm frightened that I'm going to end up in front of the NMC or that there's going to be a poor outcome and I'm going to be taken to court. So there's still quite a lot of work to be done around supporting midwives. But of course, we are protected. We're protected as midwives to support women to make choices. We are supported in law. There is case law that supports us to do that. We are supported within our code, whether or not it's the NMC code or whether it's the GMC. It has a huge amount of guidance around uh, supporting women and other birthing people to make choices. But also we're now starting to collect data around what those choices are looking like. But it is still creating a lot of anxiety in midwifery circles and elsewhere. It's also creating anxiety in women because women are making these choices more and more. We haven't had the evidence base. And again, if you go back and engage with some of that work that the NMC have done, they have collected data now around things like free birthing. And whilst I include free birthing in my work and discussions, it's not the only thing. That's one of those sort of end of the line um, uh, planned births. When I look at it, I'm looking at it through the whole continuum. I'm looking at, a woman doesn't want to scan. We're recommending that somebody books by 8 weeks, but actually they've decided they don't. And all of it applies, whether women are free birthing, whether women are making those more discrete decisions. What we don't have is the data, but the NMC has got some data, and I was rather excited when they presented that, I have to say. So kudos to the NMC for that. More work to be done around the country. But what are women telling us? What have women told us about, or what women told me about how they are treated when they make those choices, and how particularly language and the language that we use around these choices affects them? Well, I have a whole 100,000 word thesis that I could share with you that I had to distill into 4 key areas. So these are the ones that I'm going to share with you this evening. Firstly, particularly around the language that we use, women and other birthing people told me that they don't like the shame and stigma around categorization and labeling. So there are some quick wins in terms of the language that we use. And again, if we go back to the RCM and the work they did in their rebirth project, which is fantastic, it talks about how we can really challenge those labels around shame and stigma using someone's name rather than them being the VBAC in room 4 or the raised BMI in room 6. Makes a huge difference. Being categorized and labeled is stigmatizing and in and of itself. If you delve into the sociological literature, which I won't do tonight because I haven't got the time, you will see that stigma is acutely, there's a line to be drawn with how people are labeled, the dehumanization of them and their condition. But also clinics and pathway names. More and more what we're seeing now is that we're seeing it framed as outside of guideline. And I'll park that there because I'm going to come back to it because that's one of our quick wins. But equally, how we name our clinics, the pathways that we put women on. And what I do see a lot now is outside of guidelines, which seem a bit odd to me. But again, these are quick wins that we can put in place for our systems, for our individual language and our practice that can challenge some of those issues. Again, going into this institutional risk depersonalization and enforced timetables, one of the things that women told me around particularly language and the way that they were labeled is that they were labeled and put into a basket according to their perceived risk, whatever that looked like, and they didn't like that. It was a stigma around their body not working, the fact that of course we've given up on them already because we've already labeled them with that high risk complex woman, which of course women can be. They are complex, but they're still people. And then there's this thing around unique normativity. What might be abnormal for us and might be risky for us is normal for these women and other birthing people that are making these decisions. And again, anyone that's heard me talk about my research will know that I talk a lot about this expectation of compliance. So if we come into our care expecting women to comply with what we have recommended for them, whatever that looks like, whether it's evidence-based, whether it's not, and they then don't do that, we then label them. The language that we use, the difficult woman, the difficult person, the non-compliant woman, will immediately start to be a challenge to them, and they will withdraw from care. So there's a couple of big wins. This is what I'm going to ask you to do, is I'm going to ask you to start thinking about 2 particular terms. So the first one will not come as any shock. It's this outside of guidance. And I note that the new guidance from the NMC calls it outside of guidance or outside of guideline. And I see many, many trusts talking about outside of guideline, but this is problematic. And the reason it's problematic is because what we are doing then is we're positioning guidelines as the authority. When you look at what informed consent looks like, when you look at what informed decision making looks like, and there's some fantastic models that, again, the RCM have used and NHS England, it shows that it's a culmination, this informed decision making and consent is a culmination of the needs and wants and preferences of this woman. What is their history? what can we do? What are the recommendations? And then they making the decisions in the middle. So if we are positioning guidelines as authoritative, which we are by saying they are outside of guideline, we are then stigmatizing women. And we are making them feel that their choices, if they are not what we expect them to do, are then wrong. And that can be problematic in and of itself. So when you are naming clinics and pathways, try not to use outside of guidance. What I would like to see, and in the next sort of few years, that this term goes, that we start talking about personalised care clinics, personalised care pathways, because that's what it is. I'm with Tracy McCormack on this. That is what it is. Choice equals personalised care. And that informed decision making is about that ongoing organic decision. So that's outside of guidance as a problematic term and what we need to do about it. The next one that I'd like you to have a think about is this one. And I remember as a student midwife, which wasn't a million years ago, writing in people's notes, refused care. We then went away from that because, again, wasn't seemed to be a term that we should be using. And this is what we see now: declining care, declining a VE, declining a scan, has declined to see the midwife. But what this does again is it positions the recommendation as authoritative. They are just recommendations. When you look at what a guideline is, or even if it's a nice guideline, trust guideline, it's a set of recommendations which should be evidence-based. On the whole, we say they are, but they should be evidence-based. And if we are offering something, then there's a choice. And one of the choice has to be no. And one of the analogies that I used that I borrowed from the police was around a cup of tea. If you offer someone a cup of tea and they say no, you're not going to force them to drink it because that would not be right. That's a consent issue. So women aren't really declining care. What they're doing is they're withholding consent. And if we reframe how we think about withholding consent and declining care, what that does is it changes our mindset when women say no. We worry about declining care for a number of reasons. Sometimes it's a metric, sometimes we have to measure it. If they decline newborn blood spot screening, for example, might decline vitamin K for a well baby, they might decline all sorts of things. And then those coercive practices start to happen. And women have told me this. I've got many, many examples of making discrete, small choices where they're declining care. And actually, what they're doing is actually saying no, thank you, and it's withholding consent. So my second plea is start to think of it in that way and start to change your terminology so that it is withholding consent rather than declining care. And this is supported in the code. For midwives, the code is very, very clear that we should be supporting women in whatever those choices are, including the right to refuse, decline, and say no, thank you to care. And that is enshrined in law as well. So this is my plea to you this evening, is to reframe our language. It's a very small win, but it's something that can make a fundamental difference to women in our care, to their offspring, to their families. And this is what is going to make women come back to us and feel that they can trust us, because it's all wrapped up in consent. And that is all I'm going to say on the matter. Thank you very much.